Hello, good evening friends. Today we'll discuss about the evaluation and management of acute chest pain. Management of acute chest pain. So, how we will evaluate and manage a case of acute chest pain. So, first understand what are the causes of sudden onset, that is acute chest pain. We first understand what are the causes of acute chest pain. Acute chest pain could be due to ischemic heart disease. It could be due to ischemic heart disease like angina pectoris, or acute myocardial infarction. So, ischemic heart disease like angina and acute myocardial infarction can cause acute chest pain. Then other causes could be due to acute dry pleurisy. Acute dry pleurisy can cause acute chest pain, and it can be seen due to acute pericarditis, that is acute inflammation of the pericardium, can cause sometimes acute dry pleurisy that also causes the acute chest pain. Then other causes of acute chest pain like pneumothorax can cause chest pain, like trauma to the chest. Pneumothorax trauma can also cause acute chest pain. Then diffuse esophageal spasm can also cause your acute chest pain, and this is usually retrosternal chest pain is seen in acute esophageal. In diffuse esophageal spasm you find the retrosternal chest pain, and it is associated with dysphagia also. So diffuse esophageal spasm can cause retrosternal acute onset chest pain and associated with dysphagia, that is difficulty in swallowing. Then other causes of acute chest pain could be due to the costochondritis, and it is usually localized to the costochondral junction. It is localized. Costochondritis can also cause acute chest pain. Then other causes like you can have the malignant deposits on the ribs. On the ribs, you will find the malignant deposits occurring on the ribs that can cause chest pain, acute onset. Then rib fracture also cause the acute chest pain. Then there are other causes like the herpes zoster of the chest. We find the numerous vesicles that are very painful vesicles is seen on the chest, and this can also cause acute chest pain, that is herpes zoster of the chest. Then multiple myeloma can also cause acute chest pain. Then some other causes of acute chest pain, for example, the dissection of the ascending aorta. If there is a dissection of the ascending aorta can also cause acute chest pain. Then other causes like gallbladder disease, pancreatitis, hiatus hernia, they also cause the chest pain. Then very important cause, one more cause, is pulmonary thromboembolism. Pulmonary thromboembolism can also cause acute chest pain. Then if all the causes are ruled out and we cannot find any cause, then the cause of acute chest pain could be psychogenic, and psychogenic onset of chest pain is also known as cardiac neurosis. Cardiac neurosis patient, this patient having psychotic complaints and having the chest pain, which is psychogenic chest pain. That is psychogenic chest pain is called as cardiac neurosis. So these are the certain causes of the acute onset chest pain. We again revise. We are discussing the evaluation and management of a case of acute chest pain. The causes could be ischemic heart disease, which is like angina, and acute myocardial infarction can cause chest pain. Then acute dry pleurisy, which is seen in acute pericarditis, can also cause chest pain. Then pneumothorax, trauma, diffuse esophageal spasm, in which we find the retrosternal chest pain with dysphagia. Then costochondritis, it usually causes the localized chest pain. Then other causes like malignant deposits on the ribs like rib fracture and herpes zoster of the chest, multiple myeloma. Then other causes like dissection of the ascending aorta, pulmonary thromboembolism, then gallbladder disease, pancreatitis, hiatus hernia. Then last is the cardiac neurosis, which is psychogenic chest pain. Then how we will evaluate? We first take the history. We take the history. And the history, we have to note certain point of the chest pain. For example, we will inquire about the onset, whether it is sudden or gradual onset of the chest pain. Then we will take whether it is progressing or regressing. Progression, we will note it down. Onset, we will note it down. Then we will see whether the pain, relationship of the pain with movement, pain relationship with movement, we will note it down. Then actual site and character of the pain. What is the character, what is the site where it is occurring, what is the character of the pain, what are the aggravating and what are the relieving factors, what are the aggravating and relieving factors for the pain, and what is the duration of the pain, what is the duration of the pain. Then any relation with food, we will note it down. Relation with food, we will note it down. What is the relation with food? Then we also note down the associated symptoms. Associated symptoms, for example, in MI, the pain patient usually have profuse perspiration or profuse sweating. Profuse sweating, associated symptoms like sweating can be seen with acute myocardial infarction, chest pain, and vomiting also. Vomiting and sweating with acute chest pain, we should think of acute myocardial infarction. Then we also noted down whether dyspnea is present or not, whether dyspnea is there or not. And usually we see the dyspnea in conditions associated with chest pain like acute myocardial infarction, like pulmonary thromboembolism, like dissection of the ascending aorta, dissection of the aorta. These conditions are associated with dyspnea, acute myocardial infarction, pulmonary thromboembolism, dissection of the ascending aorta. And we also see whether the patient is in shock or not. For example, in acute myocardial infarction, patient can go in cardiogenic shock, and like in conditions like your pneumothorax, patient can go in shock in pneumothorax. And in pulmonary thromboembolism and tension pneumothorax, acute myocardial infarction, this patient can go in shock. So if a patient having the chest pain and the patient is in shock, you should think of acute myocardial infarction, pulmonary thromboembolism, and tension pneumothorax. This is pneumothorax, this is tension pneumothorax, this is pulmonary thromboembolism, and this can cause your chest pain with shock. And we also noted down what is the radiation, what is the radiation of the chest pain. Radiation of the chest pain, radiation of the chest pain, you have to note it down. And any personality disorders to rule out cardiac neurosis. Personality disorder, personality disorder. Then what are the causes of retrosternal chest pain? This is important, you should be knowing what are the causes of retrosternal chest pain. Retrosternal chest pain. So retrosternal chest pain, the causes could be acute myocardial infarction, can cause retrosternal chest pain. Then dissection of the aorta, dissection of the aorta can cause retrosternal chest pain. Then pulmonary thromboembolism, pulmonary thromboembolism can cause retrosternal chest pain. And diffuse esophageal spasm, diffuse esophageal spasm can cause, already discussed this point, diffuse esophageal spasm. Then pericarditis, pericarditis and psychogenic, these can cause, all can cause your retrosternal chest pain. Acute myocardial infarction, dissection of the aorta, pulmonary thromboembolism, diffuse esophageal spasm, pericarditis and psychogenic, they can cause retrosternal chest pain. Then on the history, we have to note out the character. What is the character of the chest pain? Character. So if we are getting the tenderness, chest pain with tenderness, chest pain with the tenderness, you find it in dry pleurisy, dry pleurisy, you will find the tenderness. Then if there is a trauma, trauma also cause tenderness, trauma can cause tenderness on the chest, dry pleurisy can cause tenderness on the chest. Then costochondritis can cause your tenderness on the chest, costochondritis can cause tenderness on the chest. Then any musculoskeletal disorders, for example, if there is a malignant deposits on the ribs, rib fracture, herpes zoster can cause local tenderness, multiple myeloma. So these are the musculoskeletal problems like ribs, malignant deposits on the ribs can cause localized tenderness, rib fracture can cause local tenderness, herpes zoster of the chest, multiple myeloma. So if you are getting a patient with chest pain and you are finding the tenderness over the chest, you should be thinking about your dry pleurisy, trauma, costochondritis, malignant deposits on the ribs, rib fracture, herpes zoster of the chest, and multiple myeloma. So these things you have to keep in your mind. You are getting the chest pain and tenderness. These are the causes. Then about the character, what are the pleuritic chest pain? You should be knowing what are the types of pleuritic chest pain. Pleuritic chest pain. Pleuritic chest pain you will see in dry pleurisy. You will see in dry pleurisy. Dry pleurisy you find the pleuritic chest pain in dry pleurisy. Then in pneumothorax. In pneumothorax you will find the pleuritic chest pain. Pleuritic chest pain in pneumothorax. And pulmonary thromboembolism. So 3 P's for pleuritic chest pain: pleurisy, pneumothorax, pulmonary thromboembolism. You find the pleuritic chest pain. Then retrosternal chest pain, about the character. Then retrosternal chest pain, we already discussed the retrosternal chest pain. We have discussed various causes, but retrosternal chest pain with dysphagia, it is seen in diffuse esophageal spasm. That is retrosternal chest pain with dysphagia. That is diffuse esophageal spasm. Then another cause is if you are getting, this is the chest wall and you are getting the diffuse chest pain with tenderness, diffuse chest pain with tenderness all over, diffuse chest pain with tenderness all over, then this could be due to your trauma. Trauma can cause diffuse chest pain and tenderness all over, and also in cardiac neurosis, that is psychogenic. There is diffuse chest pain and tenderness all over the chest, that is cardiac neurosis, that is psychogenic. So trauma and psychogenic chest pain are the causes for diffuse pain and tenderness all over the chest. So this was about the history. I will repeat again history in short. So you should be knowing in history, you should know what is the onset of the chest pain, what is the progression of the chest pain, whether pain is occurring with movement, what is the site of the pain, what is the character of the pain, whether there is aggravating and relieving factor, you should note it down. What is the duration of the chest pain, what the relationship with the food, any associated symptoms like sweating and vomiting is associated with acute myocardial infarction. Then dyspnea associated, if there with chest pain, then you should think of myocardial infarction, pulmonary thromboembolism, then dissection of the ascending aorta. And if the chest pain with shock, you should think of myocardial infarction, tension pneumothorax, pulmonary thromboembolism. Then radiation of the chest pain, any personality disorder, you should note it down. Then retrosternal chest pain seen in myocardial infarction, acute dissection of the aorta, pulmonary thromboembolism, diffuse esophageal spasm, pericarditis, and psychogenic. Psychogenic is also called cardiac neurosis, and it is retrosternal. Character of the pain, you should note out whether the chest pain is associated with tenderness. If you are getting the tenderness with chest pain, you should think of dry pleurisy, trauma, costochondritis, malignant deposits on the ribs, rib fractures, herpes zoster of the chest, multiple myeloma. Then you should be knowing what are the pleuritic chest pain. Pleuritic chest pain you see in pleurisy, pneumothorax, pulmonary thromboembolism. Then retrosternal chest pain with dysphagia, you should think of diffuse esophageal spasm. Then if you are getting diffuse chest pain and tenderness all over the chest, you should think of trauma or psychogenic, that is cardiac neurosis. So this was about the history of chest pain. Now we'll see examination finding, examination of a patient of chest pain, examination of chest pain. Then in examination, you can see the pallor, that is ashen gray pallor, ashen gray pallor. You should note it down, ashen gray pallor. Then you will note it down the pulse rate, blood pressure, jugular venous pressure, and cyanosis, edema, decubitus, features of shock, rhonchi, crepitations, pleural rub. These should be searched and examined. So what are the examination findings in a chest pain? You should be looking about the pallor, pulse rate, blood pressure, jugular venous pressure, cyanosis, edema, decubitus of the patient, features of shock, rhonchi, crepitations, pleural rub. So these are the examination findings. You have to note it down in a patient with chest pain. Then what are the investigation you are like to perform? If one investigation has to be done, then that one investigation is ECG, electrocardiogram. Very important. If you are sitting in the emergency and you are finding a patient with chest pain and you are asked to do one investigation only, then you are going to do the ECG. This is very important. Then another investigation you are going to do is chest x-ray. Then other investigations like cardiac enzymes, creatinine kinase, MB, then trop I. These are for myocardial infarction you will going to do. Then you can also do the ultrasound of the abdomen, UHG of the abdomen, because certain diseases of the abdomen can present as chest pain. For example, gallbladder disease, pancreatitis, hiatus hernia. These things can present as chest pain. So ultrasound of the abdomen is also important. Then also you are like to do the D-dimer for pulmonary thromboembolism, and upper GI endoscopy, and barium swallow. So what are the investigations you will like to do? First is the ECG, then chest x-ray. First is the ECG, then chest x-ray, then cardiac enzymes like trop-T, I, creatinine kinase, MB, ultrasound of the abdomen, D-dimer for pulmonary thromboembolism, upper GI endoscopy, and barium swallow. These are the investigation. Now we'll outline the management. First, we will manage the case of angina pectoris. That is the chronic stable angina. Angina pectoris. We first manage it. This chronic stable angina is due to fixed erythromatous stenosis. So chronic stable angina is due to fixed. This is the blockage is fixed. This block is fixed. Fixed erythromatous stenosis causes the chronic stable angina. We see how we will manage a case of chronic stable angina. So for chronic stable angina, we will, for acute attack, if you are getting the acute attack of chronic stable angina, you first give the isosorbide dinitrate, isosorbide dinitrate, and the dose is 5 milligram per tablet. Isosorbide dinitrate 5 milligram per tablet. This for the acute attack of chronic stable angina. chronic stable angina, for acute attack, you are going to give the isosorbate dinitrate, or you can also give your glycerol trinitrate or isosorbate dinitrate. And for glycerol trinitrate, the dose is 0.5 mg per tablet. It is more potent. Glycerol trinitrate 0.5 mg. Isosorbate dinitrate, the dose is 5 mg per tablet. Then this you are going to give, how you are going to give, you are going to give the sublingually, one tablet you will place sublingually. And this glycerol trinitrate can also be used as spray form. You can also use it as a spray, glycerol trinitrate. The route of administration is the sublingual. You will place it sublingually, and usually the pain gets relieved in 2 to 5 minutes. The chest pain gets relieved in 2 to 5 minutes. If it is not relieved, this pain is not getting relieved with glycerol trinitrate or isosorbate dinitrate, then what you are going to do, you will repeat, and you will repeat after 10 minutes. You will repeat the dose after 10 minutes. You will repeat the dose after 10 minutes. And you can repeat it for 2 to 3 tablets. You can go for 2 to 3 tablets. If it is still not getting relieved, then you should think of acute myocardial infarction. If it is not relieved, that is, it is refractory to the nitrites. For 2 to 3 tablets you have given for a chest pain and it is not getting relieved, you should think of acute myocardial infarction. Very important. Patient comes to the emergency, you thought it is chronic stable angina, you give him the nitrate tablets, not getting relieved, you tried it for 3 times, not getting relieved, you should think of acute myocardial infarction. So this is the for acute attack. You have given the nitrate, then you are also going to give the aspirin. Aspirin, you can give it at a dose of 75 to 150 mg, 75 to 150 mg orally, 75 to 150 mg orally, and it has to be continued indefinitely as 1 tablet daily after the meal. So after food you will give it, after meal daily. You first given stat and then continued indefinitely. Then you can also give the clopidogrel. The dose is 75 mg, and it can also be given lifelong. Aspirin and clopidogrel. Then other thing you can give for anxiety, you can give the alprazolam. The dose is 0.25 to 0.5 milligram per tablet. 0.25 to 0.5 milligram per tablet. You have to give the one tablet stat, and then you will repeat SOS to decrease the anxiety. So patient with chest pain and having the most of the time anxiety, you will relieve their anxiety by giving them the alprazolam, that is 0.25, and then 0.5 per tablet is 0.25 to 0.5. You give the one tablet stat and then SOS to relieve the anxiety. You can also try the diazepam tablet instead of alprazolam. You can try the diazepam, that is 5 mg tablet instead of alprazolam. You can give the diazepam 5 milligram tablet. So we are discussing the acute attack of chronic stable angina. So if the acute attack occurs, you will give the nitrate, aspirin, clopidogrel, alprazolam. Then You now prevent the further attacks. For the prevention of further attacks of angina, what you are going to do? Prevention of further attack. You will say that the patient should avoid smoking, quit smoking, so that it does not worsen, quit smoking, and avoid strenuous activity, avoid exertion, avoid exertion, quit smoking, avoid weight gain, avoid weight gain, avoid stress, psychic stress, avoid stress. So for preventing the future attacks, you will advise for smoking cessation, avoid exertion, avoid weight gain, avoid psychic stress. Then you will also advise the salt restriction, fat free diet, and light diet. So salt restriction, fat free diet, light diet, this you will advise for preventing the further attacks. Then you have to continue the isosorbide dinitrate, one tablet, one tablet, one tablet 4 times daily. Continue isosorbate dinitrate, one tablet. Isosorbate comes in the form of 5 mg per tablet. So you will give it 4 times per day, but there is a risk of headache with isosorbate dinitrate. Then isosorbate mononitrate may be used instead of isosorbate dinitrate. If there is a headache occurring, you can try the isosorbate mononitrate. It has to be taken. It's 20 mg per tab. There is a dose of 20 mg per tab, and this 20 mg per tab you can give it BD dose. It is given in twice daily, 20 mg here and 20 mg here, and there is less risk of headache. So the actual timing, it is first tablet of isosorbate mononitrate is given at 8 am, and the second tablet it is given at 3 pm. And this is known as eccentric dosage schedule. So if you are you have to give the isosorbate dinitrate or mononitrate. If there is a headache, you should give mononitrate. 8 am and 3 pm is the BD dose of isosorbate mononitrate. Then for preventing the future attacks, you will prescribe the beta blockers like propranolol. You will prescribe 40 mg twice daily. You will give the propranolol, or you can also give the atenolol. You can give the 100 mg OD. Atenolol is 100 mg OD, or you can also give the bisoprolol, which is the dose is 5 to 10 mg OD. So you can give the beta blockers like 40 mg BD dose or 100 mg OD dose, or bisoprolol 5 to 10 mg OD dose. You can try any of them. This has to be continued for preventing the future attacks. This is beta blocker. Then you can also give the calcium channel blockers for preventing the future attack. Calcium channel blockers, like you can give the nifedipine. The dose is 10 mg. Given 6 to 8 hourly daily. You can give either TDS or 4 times a day dose. This is 8 hourly, this is 6 hourly. Either of these you can give nifedipine 10 mg. Or you can also give the amlodipine. amlodipine. The dose ranges from 2.5 to 10 mg. Amlodipine 2.5 to 10 mg. You can also give the verapamil, verapamil, verapamil. The dose is 120 to 240 mg 8 hourly. That is, the dose is tedious 8 hourly. Verapamil, amlodipine you can give 3 times a day. The dose for verapamil is 120 to 240 mg. Orally you are going to give this. The dose is oral verapamil. The tablets come in the oral form. The tablet verapamil you are going to give 120 to 240 mg 3 times daily. Or you can, for other than verapamil, you can try the diltiazem. So diltiazem you can give at a dose of 60 to 120 mg orally 3 times a day. It is also given orally 3 times a day. Diltiazem. Okay, then I would like to highlight here that beta blockers which we were using, that is your propranolol, atenolol and bisoprolol. What they do is beta blocker will reduce the myocardial oxygen demand. It will reduce the myocardial oxygen demand by reducing the heart rate and contractility. Myocardial contractility and heart rate. The beta blockers, that is propranolol, atenolol, bisoprolol, they will reduce the heart rate, they will reduce the contractility of the heart, and in this way they will reduce the myocardial oxygen demand. Now also I would like to tell about the calcium channel blockers, how they will help. Calcium channel blocker also reduce the myocardial oxygen demand. They also reduce the myocardial oxygen demand by relaxing the coronaries. They will relax the coronary arteries. And causing vasodilation. They cause the vasodilation. By relaxing the coronary arteries and by causing the vasodilation, they reduce the myocardial oxygen demand. Other drugs that are prevent the future attacks of myocardial infarction, we can prescribe the potassium channel activator. Potassium channel activators. So the potassium channel activators, we have the nicorandil. Nicorandil. They will increase the blood flow to the heart. Nicorandil. The dose of nicorandil is 10 to 30 mg BD dose. It is given orally. It is also helpful. Nicorandil. Now again, for the prevention of future attack, you can, for Prinzmetal angina, there is, this angina is a variant angina. There are paroxysms of chest pain. For Prinzmetal angina, you can give the nifedipine 8 hourly orally. You can add nifedipine. The dose is 5 to 20 mg 8 hourly. That is tedious dose you can give for Prinzmetal angina. You will add the nifedipine. Then you have to, for preventing the future attack, you have to regularly check the blood pressure and ECG. Regular BP and ECG checkup should be done. Then stress ECG, that is the treadmill test and echocardiography may be performed. It should be performed. Regular blood pressure and stress ECG and echocardiography, this has to be regularly performed. The patient is advised to carry, this line is very important, the patient is advised to carry isosorbide dinitrate, that is the 5 mg tablet. The patient is advised to carry this tablet, or other than isosorbate dinitrate, glyceryl trinitrate, glyceryl trinitrate 0.5 mg per tablet. The patient should carry with him, and it should be kept under the tongue whenever the patient is having the chest pain. So isosorbate dinitrate or glyceryl trinitrate patient should always carry with it, and it should be kept under the tongue whenever there is chest pain. And if there is uncontrolled angina despite the other measures, angina pectoris is uncontrolled angina, then you will go for coronary angiography. We will go for coronary angiography if there is uncontrolled angina pectoris. Then other things we have to see for preventing the future attack is your associated systemic hypertension, diabetes mellitus, hyperlipidemia. Hyperlipidemia should be treated by diet and drugs. Diabetes, hypertension and lipid profile should be controlled with diet and drugs. This you have to remember. Hypertension, diabetes, lipid profile has to be controlled. We also have to correct the exaggerating factors contributing to the angina. That could be your obesity, congestive cardiac failure, CCF, and obesity, anemia and hyperthyroidism. So exaggerating factors for the angina like obesity, congestive cardiac failure, anemia, hyperthyroidism, you have to control it. This is important. Obesity, heart failure, anemia, hyperthyroidism, you have to control for preventing the future attack of angina. As we already discussed, in intractable angina, that is refractory angina, is called intractable angina. Intractable angina. For intractable angina, you are going to do the coronary angiography with a view to undergo coronary artery bypass grafting or percutaneous transluminal coronary angioplasty. Percutaneous transluminal coronary angioplasty. So if there is an intractable angina, the options are you can do the coronary artery bypass grafting or percutaneous transluminal coronary angioplasty. Okay. Now few more points about the management. This angina pectoris was first described by, who described the angina pectoris? Anyone? Angina pectoris was first described by Heberden. Heberden first described the angina pectoris in 1772. Other important points that the internal memory artery or saphenous vein, they are used for coronary artery bypass grafting. So internal memory artery, saphenous vein, they are used for coronary artery bypass grafting. So इतना पता होना चाहिए. अब देखते हैं angina without coronary occlusion may be seen in severe myocardial hypertrophy. अगर पेशेंट को angina है, ओके, बट उसका coronary में कोई ब्लॉकेज नहीं है, without coronary occlusion, no occlusion is there, coronary is normal, but still patient have the angina, then you should think that it may be due to severe myocardial hypertrophy. Myocardial hypertrophy हो गया है, but उसका coronary is normal है, that is causing the chest pain, that is angina. Myocardial hypertrophy is there, severe myocardial hypertrophy is there, and it is causing the angina. Or there can be possibility of severe aortic stenosis. Severe aortic stenosis or aortic regurgitation, that is causing your angina, but there is coronaries are बिल्कुल normal, coronaries are absolutely normal, लेकिन फिर भी पेशेंट को चेस्ट पेन हो रहा है, that is angina without coronary occlusion is may be possibility of myocardial hypertrophy, severe AS, that is aortic stenosis, or severe aortic regurgitation, or also severe anemia, hyperthyroidism. Coronary are absolutely normal and the patient having the angina, then you have to think severe anemia, severe hyperthyroidism, severe aortic stenosis, severe aortic regurgitation. Then one more cause for angina but coronaries are normal is paroxysmal atrial tachycardia, paroxysmal atrial tachycardia with rapid ventricular rate, paroxysmal atrial tachycardia with rapid ventricular rate. It is also one condition where you find the coronary is absolutely normal but the patient is having anginal symptoms. Now I will tell you the mnemonic for the treatment and secondary prevention of angina pectoris. The mnemonic is A, B, C, D and E. This is for treatment and prevention of angina. So what is the ABCD? A is aspirin, an anti-anginal drug. Aspirin and anti-anginal drugs. Aspirin and anti-anginal drugs. Then B is beta blocker and blood pressure control. Beta blocker and blood pressure control. Then C is cessation of smoking and control of the cholesterol. Cessation of the smoking and control of the cholesterol. Then diet modification and diabetes control. Diet modification and diabetes control. And E is education, for example lifestyle modification, education for lifestyle modification and exercise training. So ABCD for the prevention and treatment of angina is you will give the aspirin or anti-anginal drug, beta blocker and BP control, cessation of smoking and control of the cholesterol, diet modification and diabetes control, education for lifestyle modification and exercise training. So this was about the acute attack of angina.